Good morning. Uh, we're going to discuss about bronchial asthma. Uh, I think the cough, both dry cough and productive cough, has been discussed earlier. So another common condition which affect the respiratory tract, the respiratory system, is the bronchial asthma. Of course, many of us are experienced the problem in different degree. Maybe some people would have affected in a mild way, and some people still having the problem, and some people can have the worst scenario of bronchial asthma. It depends the conditions. All right. So it's need not to be explained like how it could be the condition affect the person's day-to-day life, especially the quality of life. So definitely this is a condition where we need to address properly. Good morning. Welcome back to the second part of treatment of or the pharmacotherapy of bronchial asthma. We have been talking about the different groups of drugs used in the different context of bronchial asthma, which includes as prophylactic agent as well as uh, terminating an acute attack of asthma. So I told you the short-acting beta-2 agonists like salbutamol, terbutaline, etc. are wonderful drugs to produce symptomatic relief. Now let's see what are the clinical use of beta-2 agonists in terms of the context of treatment of asthma. These are the first line therapy in acute asthma. Please remember, acute asthma, especially the shorter acting sympathomatics like salbutamol, metoprolol, terbutaline, these are the short acting drugs, are the drug of choice for acute episodes of bronchospasm. As a drug of choice for the acute episodes of bronchospasm. Usually the effect lasts for 4 hours or less, and they are not effective for prophylaxis because the short duration of action make it or render it used repeatedly, and that is having quite cumbersome. It's quite cumbersome. And the long-acting beta agonists, as we discussed, salmeterol and formoterol, should be used for prophylaxis, in which the 12-hour duration of action is useful. So maybe a two times therapy can cover around the clock. This is what the advantage of LABA when it is used in the prophylaxis of asthma. They should not be used for acute episodes because its onset of action is too slow. Because to terminate an attack, we require a drug which is rapidly acting, and LABA is not so. If used alone, they increase asthma mortality, whereas in combination with the corticosteroids, they improve control. So, as we discussed the receptor pharmacology, there we emphasize that there is something called down receptors, a down regulation of the receptors, where the continuous exposure of receptor to an agonist gradually decrease the response due to various molecular mechanism. So this is another scenario where if you're using alone these group of drugs, it gradually increase the mortality associated with the asthma. But nowadays it is quite recommended with a combination with the corticosteroid therapy. In almost all patients, the shorter acting beta-2 agonists are the most effective bronchodilators. So we have muscarinic blockers and we have methylxanthines. So compared to all these drugs, these are the most effective drugs for the acute termination of the asthmatic attack, which is available and are life-saving for acute asthma. So you have seen that patients taking metered-dose inhaler in acute, the severe asthmatic wheezing and other problems like wheezing and breathlessness, shortness of breath, etc. Even patients with COPD, chronic obstructive pulmonary disease, also benefit, although the risk of toxicities increase in this condition. Okay, so this is occasionally used in the management of COPD also. Now, what are the adverse effects or the toxicity of beta-2 agonist? It is, of course, we have discussed the pharmacology of autonomic nervous system. So you know that skeletal muscle tremor is a common adverse effects with beta-2 agonists. And even though we call it as a selective beta-2 agonist, the selectivity is actually relative. When you use a higher doses of these drugs, it may lose its bit selectivity and can even stimulate beta-1 receptors. They are given by inhalation. Some cardiac effects, tachycardia is common. See, I told you this is inhalation route. 20% is directly deposited in the alveoli and other part of the respiratory tract, whereas 80% is eventually the fate of the 80% molecule, the fraction get absorbed from the GI, because it reached to the GI tract and from there it is absorbed. So this can get absorbed from the GI and causes the systemic toxicities or the adverse effects, including fallen BP. Therefore, the tachycardia can be manifested. And the excessive use of these drugs can produce the arrhythmias, especially the tachyarrhythmias can be manifested. And tolerance and tachyphylaxis is a common phenomenon when you use continuously these drugs, because it, as I told you, the problem called the downregulation of the receptors, which is already discussed. Patients with COPD often have concurrent cardiac diseases and may have arrhythmias even at normal dosages. So that's very important point to be noted. Now let's talk about the second group of drugs. This is also drugs used in the acute termination of asthmatic attack, and these are bronchodilators. And we have seen that methylxanthines are basically smooth muscle relaxants, and it inhibits the phosphodiesterase enzyme, therefore increase the cyclic AMP level, which in turn activate the protein kinase A and other molecular mechanism. Eventually it produce or provide the smooth muscle relaxation, including the tracheobronchial smooth muscles. So methylxanthines are purine derivatives. These are the natural products. Three major methylxanthines are found in plants and provide the stimulant effects, CNS stimulant effects of three common beverages: caffeine in coffee, theophylline in tea, and theobromine in cocoa, chocolate. So theobromine is the CNS stimulant contained in cocoa, that is your chocolate. Theophylline is the only member of this group that is important in the treatment of asthma. So none of other drugs like caffeine is not used, or even theobromine is not used. The pharmacokinetics, theophylline, whenever we talk about theophylline, it follows a narrow therapeutic safety margin. The congeners like ostrifilin, diphylline and derifylline are orally active and available as various salts and as the base. It is available in both a prompt release and slow release form. See, suppose if you want to have acute termination with a short term effect, you can use the short acting in the prompt releasing preparation, and the sustained release preparations or the control release preparations may be used for the prophylactic purpose. It is eliminated by cytochrome P450 enzyme, and I already told you it follows a very narrow safety margin. Clearance varies with the age, highest in young adolescents. Smoking status, or the smoking people may have a higher metabolic rate. Concurrent use of other drugs that inhibit the or induce the hepatic enzyme. So you know the common examples for the drugs which inhibit the cytochrome P450, especially CYP2C9, CYP3A4, etc. And those agents which induce the enzymes, say for example like phenobarbital or isoniazid, etc. So mechanism of action, here this is a same slide we discussed earlier. This is what happened. Theophylline inhibit the phosphodiesterase enzyme. Phosphodiesterase has different isoform: PD1, PD2, PD3. Okay, so the PD2, I think it's PD2. I'm not sure. Like, I just want to clarify it is PD2 or PD3, because some phosphodiesterase enzyme is predominant in the cardiac tissues. Some of them are the located on your eyes. Some of them are located on the penis, sildenafil. Viagra is another phosphodiesterase inhibitor. All right. So PDE inhibition leads to accumulation of cyclic AMP because PDE is responsible for the conversion of cyclic AMP or the metabolism of cyclic AMP into AMP. Fine. So the cyclic AMP can act on the smooth muscle by activating protein kinase A, which in turn produce the smooth muscle relaxation. So we are talking about the smooth muscle bronchial asthma, and hence what happened? It can produce smooth muscle relaxation. So this is a major mechanism. Other mechanism includes also enhance the histone deacetylase activity, which also contribute its muscle relaxant property. And concurrent use of corticosteroids partially act by recruiting histone deacetylators to the site of inflammatory gene transcription. So it can have an anti-inflammatory sort of anti-inflammatory effect. Okay. Then see these are the overall. You can see this is like structural cells. It causes bronchodilatation. We have seen it reduces the gap between the endothelial cells. Therefore, it reduces the leak of fluids. So the edematous and the inflammatory status can be reduced. Respiratory skeletal muscle can be strengthened, and so the diaphragm and also the external oblique and other muscles, respiratory muscles will be strengthened. So which eventually promote your respiratory process. Now, inflammatory cells, it reduces the cell number of the eosinophils and increase the apoptosis, reduce the cytokines traffic in case of T lymphocytes. Then mast cells, it reduces the mediators release, especially the antigen antibody reactions may be interfere, and the release of histamine from the mast cells can be decreased. And on the macrophages, it reduces the cytokine formation. So these are the overall mechanism of action of thiophyllene. What are the effects of methylxanthine? In asthma, bronchodilation is the most important therapeutic action of thiophyllene. See, thiophyllene may have as an add-on effect, okay, pleiotropic effect. It is anti-inflammatory and it has got anti-chemotactic effects, etc. But predominantly the effects, the rationale of use is mainly promoted because it is smooth muscle relaxant. Increased strength of contraction of the diaphragm, it's seen in some patients. CNS stimulation, you've seen that caffeine, cocaine, etc. Not cocaine, the cocaine, thiobromide. Cardiac stimulation, vasodilatation. Vasodilatation, of course, it can be explained by the smooth muscle relaxation. Increased GI motility. Now, what are the toxic profile of thiophyllene and its congeners? GI distress, trauma, and insomnia. Because being a CNS stimulant, it produces insomnia. Nausea and vomiting is very common. Hypertension, cardiac arrhythmia, and seizures. The tendency to develop seizures are very high, and it is a result of overdosage in many people. Still higher doses, large doses, especially during the homicidal attempt or the suicidal attempt, lethal because it precipitate arrhythmias and seizures. So severe arrhythmias can be manifested, and of course seizures is also breakthrough. So suppose if somebody developed toxicity due to methylxanthines, you can use beta blockers to reverse the severe cardiovascular toxicity from thiophyllene. So tachycardia is a major problem, so that can be addressed with the beta blockers, because beta blockers can it can reduce the heart rate. Now let's go to the third group. It is muscarinic antagonists or anticholinergics. So you have seen we have learned about the detailed pharmacology of antimuscarinic agents. We have M3 receptors on various smooth muscles, including bronchial or the respiratory smooth muscles. Now, when you talk about the two drugs, one is ipratropium bromide and tiotropium bromide, which is specific to the smooth muscles on the bronchial area or the tracheobronchial tree. So ipratropium, tiotropium is the common drugs used in which are specific to the tracheobronchial smooth muscles, and these are the common drugs used in bronchial asthma. Whereas when you consider atropine and other congeners, these are non-specific because it can act all the muscarinic receptors, including the heart, and it can produce the tachycardia and other problems. Okay, and of course it can produce the anticholinergic side effects, which includes your photophobia due to mydriasis and problem with the distant objects or the near objects, vision with the problem with the vision of near and distant objects. See, if a person use anticholinergic, will have cycloplegia. So cycloplegia will make the person's near vision difficult. Okay, so these are the problem that can be anticipated when you use non-specific drugs. So the ipratropium, it's a quaternary compounds, which means wherever you hear the term quaternary compounds, these are lipid insoluble. It cannot cross the blood-brain barrier. Okay, and this is prepared for or designed for aerosol use. So ipratropium metered-dose inhale preparations are available. It is delivered to the airways by pressurized aerosol and has little systemic action. Because I'll tell you why. The 20% which enter into directly into the lungs and the other area is mainly responsible for its effect. And being a quaternary compounds, where 80% which reach to the systemic circulation through the GI, not systemic circulation, enter into the GI tract, is failed to absorb because it is lipid insoluble. Okay, so the major effect of ipratropium and tiotropium, which is given through aerosol, is a direct effect on the tracheobronchial gland. Now the mechanism, I think it is well understood that it is directly act on the muscarinic receptors on the tracheobronchial gland. Usually the muscarinic acetylcholine act on the M3 receptors on the tracheobronchial smooth muscles and glands and produce the bronchospasm and increase secretion. Now this is going to block these actions and produce mainly the smooth muscle relaxation. Fine. So here the normal tracheobronchial tube, where the actions of the ACH, it produce the constriction, highly constricted effect, and of course when you use the anticholinergic, it relieves the spasm. Okay, so muscarinic antagonists reduce the spastic condition. This is the effect of muscarinic antagonists. So there's nothing to discuss regarding the mechanism, because it is antimuscarinic and produce its effect by blocking the actions of ACH on the muscarinic receptors, and which muscarinic receptor, to be specific, the M3 receptors on the tracheobronchial tree. So what are the effects of antimuscarinic agents? It reverses the bronchoconstriction in some asthma patients, especially children, and many patients with COPD. They have no effect on the chronic inflammatory aspects of asthma, means which doesn't alter the inflammatory process. It provides only symptomatic relief by producing bronchodilation. Now, what are the clinical uses? Ipratropium and tiotropium are useful in 1/3 to 2/3 of asthmatic patients. Beta-2 agonists are the effective in almost all. So, it is inferior to beta-2 agonists. In acute bronchospasm, the beta-2 agonists are usually preferred. This is what we have discussed earlier. In COPD, the antimuscarinics are more effective and less toxic than beta-2 agonists. Now, what are the toxicities we have discussed? And I wanted to tell you, when you use ipratropium and tiotropium, these are the local action. It produces local action and the systemic effect will be less. But still, you should anticipate some amount of the toxicities or when you give a large dose of antimuscarinic drugs or the atropine-like drugs, or it produces atropine-like effects. And it block all the exocrine secretions and it produces the photophobia and cycloplegia. Then it can produce the GI effects. Okay, so these are the problem. Now the fourth group of drugs are mast cell stabilizers. Mast cell stabilizers are basically a group of drugs which stabilize the mast cell membrane, because when there is an antigen antibody reaction takes place, it disrupts the membrane and release the histamine, and histamine is a potent bronchospastic agent. Further, the actions of histamine can further invite the other inflammatory changes and causes leukotriene formation or the generation, and that can contribute severe bronchospasm. So these are the cascade pathway where the mast cell contribute release of mast cell, release of histamine and other inflammatory mediator for mast cells is the triggering factors of the inflammatory events during asthmatic attack. So what I want to tell you, mast cell stabilizers are always, there is no role in acute asthmatic attack. As far as the mast cell stabilizers are concerned, there is no effect. There is no acute effect in the acute termination of attack. Cromolyn, disodium chromoglycate, and nedocromyl are the two drugs used, and it is insoluble chemicals. Massive doses given orally or by aerosol result in minimum systemic blood levels. Of course, this is always given as aerosols. Cromolyn is the prototype of this group. These are drugs decrease the release of mediators such as leukotrienes and histamine from mast cells, and of course from eosinophils also. So it can protect the membrane from the releasing of these chemokines, neutrophils, monocytes, macrophages and all, lymphocytes as well. So it protects, though it is named as mast cell stabilizers, it can protect all these cells. So the exact mechanism how it stabilizes the membrane is not clear. So as I already told you, there is no bronchodilator action as such, but it can prevent the bronchoconstriction caused by the challenge with antigen to which the patient is allergic. So you know that there are two types, extrinsic and intrinsic asthma, and one has got the immunological profile involved. So the antigen antibody reaction can elicit the mast cell membrane disruption and release of the components, as I told you, leukotrienes and histamine, etc. So that can be prevented. And please remember, it is never used for the acute termination of attack. There is no role as far as the mast cell stabilizers are concerned. And this is already, we know this diagram we have discussed earlier. Now, what are the effects of these group of drugs? They're not as absorbed, I told you, and of course it is given through aerosol. When it is orally administered, it has some efficacy in preventing food allergy. The exact mechanism is not clear, but still it could be due to the effect on the mast cell. Similar actions are demonstrated after local applications in the conjunctiva and the nasopharynx for allergic IgE mediator reactions in this. So conjunctivitis and the allergic responses can be minimized by using the eye drops or the local drops. Now, what are the clinical uses? And I told you there is no role during the acute attack. So prophylaxis of asthma is the only indication in case of treatment of asthma, especially in children. Is the most important use for cromolyn and nedocromyl. These are the two mast cell stabilizers. Nasal, and I told you, eye drops for the conjunctivitis, and it is used for hay fever. It is an allergic response. Oral formulation is used for food allergy. Now, what are the toxicity? It can cause cough and irritation of the airway when given by aerosol, because a continuous administration can irritate your airway. So that can precipitate cough and irritation. Drug allergy have been reported in some contexts. Then there come the most widely used group of drugs for the treatment of asthma, which is corticosteroids. So once upon a time, corticosteroids been used only in the severe cases, systemically as intravenously, or even orally for the termination of a severe case of attack, especially the status asthmaticus and other severe chronic asthmas. Now it is a common practice of using the inhalational corticosteroids even in mild cases, because it is very useful, and it prevent the progression of the condition, as well as it prevent the uh, attack of asthma when it is used with other drugs like beta 2 agonist or the other bronchodilators or other anti-inflammatory agents. So it has got a distinct role in the management of bronchial asthma nowadays. All corticosteroids are potentially beneficial in severe asthma due to their toxicity. Systemic oral or the parenteral or the oral corticosteroids are used chronically only when other therapies are unsuccessful. This is what I have told you just now. In contrast, the local aerosol administration of the compounds like see the examples for the local agents, which includes fluticasone, budesonide, beclomethasone, flunisolide, dexamethasone, and mometasone. I repeat: fluticasone, budesonide, beclomethasone, flunisolide, dexamethasone, and mometasone. These are the locally used topical preparation, not topical preparation, the locally used aerosol preparations, which is relatively safer because the systemic toxicity is comparatively lesser. So therefore, it's common practice using this group of drugs in even a mild case of asthma. Now, the pharmacokinetics of steroids, of course, the systemic steroids will be discussed elsewhere, but of course, we have to talk about the local effects. Inhaled corticosteroids is a different, separate entity. It have common first-line therapy. It is a common drug for the first-line therapy of individuals with a moderate to severe asthma. So I told you it is as a common practice in moderate to severe asthma. Intravenous of corticosteroid therapy for status asthmaticus include prednisolone, the active metabolite of prednisone, and hydrocortisone. So this is still is a life-saving drug in status asthmaticus. Use of hydrocortisone or prednisolone is a common practice of treatment of severe asthma, especially in the status asthmaticus. Now, talking about the mechanism of actions of corticosteroids, you know well about the mechanism of corticosteroid because we have discussed elsewhere. It prima facie, you can easily notice that these drugs can inhibit the formation of arachidonic acid from the membrane phospholipids by inhibiting phospholipase A2. And you know, arachidonic acid is the precursor for two potent inflammatory mediators, includes prostaglandins and leukotriene. So the formation of these two mediators, inflammatory mediators, will be absolutely prevented by using corticosteroids. It also been suggested that corticosteroids increase the responsiveness of beta 2 receptors in the airway. That's why, considering this hypothesis, we use a combination of corticosteroids with beta 2 agonists, a common practice nowadays. Now, this is again, you have seen this picture. Here, corticosteroids has got a distinct effect of inhibiting phospholipase A2. Now, apart from this, it has got various other effects. It generally binds to the nuclear receptors because it's a steroid hormone. It acts on the nuclear receptors and activate glucocorticoid response elements on the gene on the nucleus. And this results in synthesis of substances that prevent the full expression of the inflammation and allergy. See, different proteins are involved in the inflammatory process. So inhibiting the gene or the gene coded for this protein can be inhibited by steroids. This is what you know that binding of molecule on the gene can cause activation as well as repression. In terms of corticosteroids, it is always repressing several genes for the synthesis of different proteins involved in the inflammatory process. This is how it acts as an anti-inflammatory agent. Now, this picture shows, you can easily see this picture shows certain mechanism. Here you can see the what are the effects of corticosteroids on the structural cells. Here you can see it reduces the cytokines and other inflammatory mediators on epithelial cells. On endothelial cells, it reduces the endothelial gap, the gap between the endothelial cells. Therefore, the leakage of the fluids reduced and the edema can be reduced. It increases the beta 2 receptors response and the mucus gland, decrease the mucus secretion. So it has got a potential anti-inflammatory effects on the structural cells. Whereas the inflammatory cells, you can see this effects on eosinophils, T lymphocytes, mast cells, macrophages, and dendritic cells. See, on eosinophils, it decrease the eosinophil count and promote the apoptosis of eosinophil. And on the T lymphocytes, decrease the cytokines level. The mast cell count can be reduced, and the macrophages, the cytokine secretions can be, because cytokines have got distinct role in the inflammatory process. The interleukins, TNF alpha, and other mediators can promote or can hasten the inflammatory process in different levels. So all these methods and mechanisms involved in the inflammatory process can be arrested by using steroids. So we can call that, or we can say that the corticosteroids are a wonderful drug as an anti-inflammatory agent, and the asthma, bronchial asthma as such, is an inflammatory condition. So definitely introduction of the inhalational asthma has got a significant role. Introduction of the inhalational steroids has got significant role in the management of asthma. So this has got a potential role. Now, what are the clinical use of corticosteroids? The inhaled steroids are now considered appropriate even for children. So there was a dilemma whether it can be used in the pediatric age group. Now it is clear that it is a common practice of using. It is a common practice. So in most cases of moderate asthma that are not fully responsive to aerosol agonists, where these are used as a combination therapy. It's believed that such early use may prevent the severe progressive inflammatory changes characteristics of long-standing asthma. Okay, so this is nowadays it is started early in mild to moderate cases of asthma. This is a shift from earlier beliefs, which I already told you, that steroids should be used only in severe refractory asthma. This is what the status in earlier, where the systemic asthma, steroids were only used for the condition. Now the introduction of this type of formulations have changed the entire concept. In such case of severe asthma, patients are usually hospitalized and stabilized on daily systemic prednisone or even hydrocortisone. They switch to inhaled alternative day oral therapy before discharge. So this is the protocol for the management of asthma, especially for the treatment of status asthmaticus. In status asthmaticus, the parenteral steroids are life-saving and apparently act more promptly than in ordinary asthma. The mechanism of action in this condition is not fully understood. It could be the same mechanism, but the action has become more prompt. Now, what are the toxicities of inhaled steroids? So, steroids, basically the systemic steroids, especially the long-term use of steroids, can produce various untoward effects. You know that it can increase the sugar level, it can cause the opportunistic infection, it can cause the osteoporosis, it can precipitate peptic ulcer, cataract, etc., and various other problems. But these are mainly applicable to the systemic use for a long-term basis. Now, we are talking about the inhalational therapy through the oral inhalation by using the metered-dose inhaler or the other preparations. Occasionally it can result in a very small degree of adrenal suppression, that is a hypothalamo-pituitary axis, and okay, but this rarely significant. This is significant only in case of systemic. See, if you're continuously using systemic therapy of corticosteroids, gradually the level of the hormones from the hypothalamus and anterior pituitary, that is your CRH and ACTH, will be reduced. And if you suddenly or abruptly stop the steroid therapy, it can precipitate acute adrenal insufficiency, because the adrenal glands will temporarily shut down because you are anyway giving external supplementation of the steroids. Now abruptly stop can precipitate the acute adrenal insufficiency. Though this is an emergency that should be promptly addressed, and that's why Systemic corticosteroid therapy should not be stopped abruptly, and the tapering of the dosage should be followed. More commonly, changes in oropharyngeal flora resulting in candidiasis. See the problem. Locally, it can promote the fungal growth, the oral candidiasis, oral thrush. It's also called oral thrush. Now, when we talk about the toxicity of inhaled steroids, let's see what are the toxicities. Local side effects includes dysphonia, sounds can be altered. Oropharyngeal candidiasis, the same problem. It is also called oral thrush, and cough due to the irritation of the airway. Systemic side effects we already discussed, but the intensity of the systemic toxicity is less when you compare with the compare with the toxicities associated with the inhalation. Adrenal suppression and insufficiency, growth suppression, bruising, osteoporosis, cataracts, glaucoma, metabolic abnormalities including increased glucose level, insulin resistance, triglycerides levels, psychotic disturbances, euphoria, depression, and pneumonia due to the opportunistic infection. The major systemic toxicities of the glucocorticoids are much more likely to occur when systemic treatment is required. I told you the same. If you are continuing the systemic treatment, it can have various other untoward effects, which is already mentioned here. It does regular inhalation steroids does cause mild growth retardation in children, but these children eventually reach full predicted adult stature. Now, the last group of drugs are leukotriene antagonists. You have seen that leukotrienes are the most potent bronchospastic agent, and this is the major culprit for the bronchospasm during bronchial asthma. Not just histamine. Histamine may be inferior in terms of the bronchospastic potential, but of course, leukotrienes have got a potential role in the bronchospasm. These drugs interfere with the synthesis or the action of the leukotrienes. Like mast cell stabilizers, this is also got potential role in the prophylaxis and no role in the termination of attack. Please remember, no role in the termination of attack. Here you go with the pathways. Here you can see the effects of leukotrienes, and this is the precursor. Arachidonic acid is the precursor, and from there the lipoxynes enzyme generate the leukotrienes, and it acts on endothelial cells and increase the exudation of the fluids, and the mucus secretion can be increased. Bronchospasm, that's the most potential or the most potent effect of leukotrienes. And eosinophil recruitment, the chemotaxis process can be enhanced or hastened by the leukotriene. So all these effects can be blocked, or all these actions is developed as a result of the actions of leukotrienes on the leukotriene receptors. The LTC4, LTD4 and LTE are the major leukotrienes. It acts on the LT1 receptors, and blocking this action by montelukast and zafilukast arrest all these effects. And I repeat, it is only having a role in the prophylaxis. So zafilukast and montelukast are antagonists at the LTD4 leukotriene receptor and block all the above said mechanism. LTE4 receptors is also blocked. There are LTD4 receptors orally active, unlike the drugs like mast cell stabilizers. This is even orally available, and it is effective in preventing excessive antigen and aspirin induced bronchospasm. And not recommended for acute episodes of asthma. And toxicity is generally low compared to other drugs. The reports of Church-Strauss syndrome. So rarely the Church-Strauss syndrome, which is actually a inflammatory conditions which mainly affect the blood vessels and can have a sort of necrosis and all. Then allergic granulomatous angiitis have appear, but an association with these drugs has not been established. The causality could not be proven. I'm sorry, one more group is the lipoxynes inhibitor, though it is not used quite frequently due to its toxic profile. So you have seen that a lipoxygenase enzyme is involved in the conversion of arachidonic acid into our leukotrienes. So that pathway can be blocked by this group of drug. And here we have one drug, it is called Xylitol. Excuse me. It's only orally active. A key enzyme, the role. Excuse me. It is also effective against aspirin allergy. Elevation of liver enzymes is an important toxicity, and this drug is therefore less popular than the receptor blockers. So it is not commonly used drug due to the hepatotoxicity or other untoward effects. Now the last one is, so the role of the reagenic. I'm very sorry. I forgot about it. I was under impression that this IgE antibody and Xylitol have discussed earlier. Okay, that's why I told you the last group. Now this is of course it's the last group. Okay, so anti-IgE antibody, because IgE is a monoclonal antibody which is responsible for it is called reagenic monoclonal. IgE is not monoclonal antibody. IgE is the reagenic antibody which is responsible for the antigen-antibody reactions and cause of disruption of the mast cell membrane and release of histamine from and even leukotrienes from the mast cells, right? So we have developed a monoclonal antibody against IgE, so which is highly effective in the progression of the inflammatory process by blocking the mast cells. Okay, so this is almost same like the effect will be same like mast cell stabilizers, but the mechanism is different because the antigen-antibody reaction will be arrested by using monoclonal antibody. We have omalizumab. It is a human IgE. It blocked the effects of IgE. The antigen antibody reaction will be blocked. Omalizumab. So this IgE antigen antibody reaction will be inhibited. Okay. So omalizumab, it was approved in 2003 for the prophylactic management. Please remember prophylactic management. And initial reports have been positive. It's very expensive and must be administered parentally. So the country like ours, where we have plenty of drugs and the people cannot afford the cost of omalizumab, so it is not popular in our country. So this is the status of omalizumab. So please understand that the monoclonal antibody against the IgE is available. Its name is omalizumab. With this, we have finished the treatment of bronchial asthma. And please listen the class carefully and carefully from the first part. And you have an assignment in connection with this class. Please submit individually about treatment and management of status asthmaticus. How do you manage or how do you treat a case of status asthmaticus? So this is your assignment after the session. So please you can prepare and keep it ready. I'll ask you to submit. Fine. So with this we have finished our class. Thank you for your patience. Thank you.